Hi everyone, good evening and welcome to our live breast question and answers session. So we'll do some introductions for you. So thank you for logging on. I'm Wendy, I'm the Macmillan Information and Support Lead at Northampton General Hospital.
Hi, I'm Ruth and I'm the secondary breast cancer nurse specialist.
Good evening. I'm Harrieta Garofide. I'm a consultant medical oncologist at Northampton General Hospital.
Hi, I'm Sharon Irison. I'm one of the breast care nurses at Northampton General.
Hi there. Yeah, so I'm Kay, dietitian. I'm part of a new team within the hospital, connected with prehabilitation, so getting people fit and ready for surgery.
So we'll start off with some questions that have come through. So a question probably for Sharon. So somebody's asked, is there a course to help manage lymphedema and show you how to move the fluid when exercises, are not working?
So with lymphedema, if people are struggling with the fluid buildup particularly in their affected arm, then it's always good to contact breast care nurses so that we can do a full assessment. And then if necessary, we've got a lymphedema nurse specialist team that we can refer to that would go through that manual lymph drainage or any other techniques that they'd be able to utilise to help manage that lymphedema. I'd say that that's probably the best course of action.
Thank you, Sharon. Harriet, this one maybe is for you. So somebody's asked, what determines the choice of scan and why does cancer show up on some scans, i.e. PET versus other CT and MRI scans?
Thank you. That's indeed a really good question because we don't tend to be very specific when we talk about organizing scans if there is a particular problem we're investigating. So the choice of imaging modality depends a lot on what is suspected because not all changes in the body related to cancer can be identified by a specific scan modality. So the CT scans of the chest, the abdomen, and pelvis that we tend to do commonly, they cover a large area of the body where cancer can spread to, and it has a good chance of identifying cancer that is spread to the lungs, the bones, the liver, or the pelvic bones. So it covers probably the majority of areas of disease spread. Sometimes cancer may spread without causing changes on CTs, but cancer cells, because they're active, they may those changes, that change in activity might be easier picked up by a different treatment modality like the PET scan, which has the element of the CT, but also uh, involves a tracer being injected, glucose basically marked, that is picked up by the parts of the body where there is activity. And then on top of the structures inside the body, we can also see the function, and we may be able to see how active some parts of the body are when the CT may not give us the basic information. Then we have MRIs, for example, that may show better structures affecting the spine or the nerves that come away from the spine. So to answer that question briefly, I would say that treat the investigation modality is chosen based on what the clinical suspicion is, and it's maybe most of the times a CT, but sometimes when we know changes are not picked up by the CT or the CT is not the modality to highlight what we suspect, we may need MRIs. Um, and all tests have limitations, and scans may show changes that measure more than, let's say, half a centimeter. Things that are very, very small may not be picked up by those investigations. I'm not sure if that answered the question, but I'm hoping it shed a little bit more light on the choice of tests we do.
Lovely. Thank you, Henrietta. And like we say, just pop anything in the chat box if you want to ask any member of the team any further questions, you know, after the answer, to make sure that we've covered what you wanted to know. So thank you for that. We've got one, Ruth, a lady I had treatment with has now been diagnosed with secondary breast cancer. What is the likelihood of me developing secondary breast and what to look out for?
Okay, I mean, still happily, the majority of patients who've had a breast cancer don't go on to have metastatic disease. I think it's roughly a third, something like that. It's always, you'll get the information when you've finished your treatment after a primary cancer from Sharon and her team, of all the things to be very aware of. Symptoms, for instance, like severe backache, something that doesn't resolve in a few weeks, that should go to the GP. Any new lumps and bumps you may find at the site where the original cancer was, any unexplained weight loss, anything really, most people know their own body, and anything really that doesn't feel right and doesn't pass in a 2 or 3 weeks is always worth running by the GP. But also, you know, breast cancers come in so many different forms, and some are just inherently higher risk than others. So we fundamentally don't know who will have recurrence, but obviously the higher the risk breast cancer you have in the first place, that will carry a little more risk for recurrence. I hope that answers your question.
Okay, thank you, Ruth. And Laura's put a slide up there as well. Thank you.
Could I just add something in there as well? Would that be okay? So we also run an open access service for patients for 5 years following diagnosis. So if there are any worries that people have with regards to new symptoms or that they develop and they're not sure, please feel free to contact the breast care nurses about those. We will guide you as to what to do. Either sometimes, as Ruth said, it will be to go back to your GP. Other times it might be we need to access either the breast surgeons or the breast oncologist for advice and guidance, potentially reviews or scans, whatever it might be. But or sometimes it might just be you need to see a breast care nurse. But please feel free to contact us. As I say, we have an open access service for the first 5 years following diagnosis.
Thank you, Sharon. Keep the questions coming in. Anything, you know, this is your chance now to ask the team of experts on the panel. So yeah, keep the questions coming in. Somebody also asked, there is a waiting list for corrective surgery. Is there an update when you will be getting the list down, please?
Shall I take that one?
Yeah, please, Sharon.
So yes, there has been quite a significant wait for corrective surgery, or we call it symmetrizing surgery. And that was probably predominantly off the back of COVID, because we weren't able to do any reconstruction through COVID. That was one of the main restrictions we had. We were very fortunate to be able to keep treatments going, but it was the cosmetic side that suffered through COVID for us as the breast team, and for our breast patients. But we've now just appointed a new oncoplastic breast surgeon as part of our team. So we now have 2 oncoplastic breast surgeons and she's been with us for probably about 6 weeks now. So we are starting to set up some reconstruction clinics. They're in process at the moment, and we are already starting to get down some of the backlog. We're doing them in sort of date order, so it's done in a fair way. So hopefully, if that question's come from somebody that has been waiting for a while, I'm so sorry you have been waiting. We've been very conscious of that, but we are trying our hardest to get down that list now for a review and an assessment, and hopefully a plan for you to have your corrective surgery.
Okay, thank you, Sharon. Somebody's asked, and it's probably for UK, any tips on losing weight post-treatment?
Yeah, I guess really, unfortunately, there's no sort of magic answer to that one. It's basically a combination of sort of healthy eating and exercise and activity. So it's the same as the whole population should be following, really. So I don't know whether you've all seen the Eat Well plate. I can put a link to it on the chat in a minute. But basically, the majority of your plate you want to sort of have filled up with carbohydrate rich foods, and ideally the wholemeal versions, so things like wholemeal bread, potatoes with their skin on, brown rice, brown pasta, things like that, so that they're nice and filling for you. And then the other part of our plate should be fill up with lots of sort of fruit and vegetables. And then the sort of smaller part of your plate should be those protein rich foods, like your meat, fish, eggs, cheese. So it's looking at the proportions of foods that you've got on your plate and the overall sort of portions that you eat as a whole. Sometimes it tends to be a little bit on snacking. So sort of, is there ways that you can sort of increase that whole meal element to your diet so that then you're less hungry between meals? So that might help a little bit. And often people find it's helpful to actually write down what they're eating, and that can be really useful to sort of look through. Macmillan have got a really comprehensive booklet on sort of healthy eating that's definitely worth referring to. So again, I can pop a link to that in the chat. But yeah, it can be sort of difficult with some of the sort of hormone treatments and things. That does make it more tricky to lose weight. So I do appreciate it's not easy. But there is some really good resources on the Macmillan website out there, and looking at sort of food labels and things as well. So sorry that there's no sort of one quick answer to that one, but I will pop a few links in the chat to some useful resources that will hopefully help. There are sort of community-wise as well, depending on what your body mass index is, there may be some access through your GP. Depending on which end of the county you live, there's slightly different access to sort of weight management sort of services as a whole. So it might be worth sort of discussing that with your GP surgery as well.
Thank you, Kay. Thank you. We've got somebody said, if the dietitian is only for surgery for mastectomies, or can this be accessed for reconstructive surgery to be able to get fit before surgery? And if so, how can it be accessed?
I guess we've not come across the reconstructive sort of surgeries, to be honest, as yet, because it is a relatively new service. But really, getting fit for any surgery is really important. The access would be through your clinical nurse specialist, that they would be able to do a referral for you. So it's worth sort of discussing with them, and then you could get referred into our service. But as yet, we've not had any referrals for that. But it's not that we won't see people who are having that reconstructive surgery, because the quicker we can help you recover afterwards, the better, really. So speak to your clinical nurse specialist.
I am due to have breast surgery. How can I prepare myself physically and emotionally?
Yes, so again, as Kay said, we're very much trying to promote the sort of prehabilitation, which is all about that. It's all about preparing both, physically and emotionally for surgery. And any patient that's diagnosed with breast cancer and we have a treatment plan for surgery, we would be performing a holistic needs assessment. So if people have specific concerns with regards to sort of preparing for surgery, that's the time to be talking to your nurse specialist about your concerns, so that we can make the appropriate referrals as necessary. And also just put in any support as necessary as well. So, if it is more emotional concerns, we can go through coping strategies with patients and point people in the right direction as to how to get them, in the best possible state prior to that surgery, so that we can make sure they have a quick and speedy recovery. I hope that answers that question. Sorry, please write it in the chat if I haven't thoroughly answered that.
And I guess from the prehab sort of side of things, from it being a really new service, we have got some really good resources. So if you have got sort of surgery on the cards, your clinical nurse specialist will sort of go through a mini sort of assessment with you, and there's access to some written resources and some videos and things that we've made. And some people will then get referred on to be seen in a either group setting or one-to-one to be supported with activity, emotion and sort of nutrition in preparation for that surgery. So hopefully this new service will really help that.
Lovely. And do you find with your ladies and men, joining a support group prior to treatment helps, or do people tend to join after treatment started, just to get that peer support?
I think it varies from person to person and an individual's preference. Some people do join straight away. They find that really helpful to sort of speak to other women, get tips and support from other women that have been through that journey themselves. And I think sometimes seeing the women that have gone through the whole thing is really positive sometimes to those women when they're at the beginning, because it can feel a very long journey ahead of them at times. For other people, it's too soon, it's too much, and they definitely prefer to do that afterwards. And you know, sort of for a lot of patients, that can even be after the end of treatment. They sort of, you know, prefer to access that once they've completed all their treatment. So it is a very individual decision. Again, sort of with any written information that we give to our patients that are diagnosed, we do give information about the Cancer Information and Support Centre and any support groups and anything that's out there for patients. But again, if it's not clear or you want to talk about it further or get more information, then again, please do contact the breast care nurses or your key worker so that we can go into that in a bit more detail for you.
Lovely, thank you, Sharon. Somebody's asked, a concern with further mammograms is that the side that has had a mastectomy, how does this get checked? I've been told that it's down to patients to check themselves, but for my part, the healing after a year is changing all the time and it feels quite knobbly. How would I know if cancer is in the mastectomy site, please?
So yeah, we wouldn't need to mammogram the mastectomy site because there is minimal breast tissue left after that particular operation, even with reconstruction. And so it is only the other breast that we use any sort of screening imaging. So it is down to sort of clinical examinations, and obviously predominantly women themselves. And I think one of the videos that we've done that's on our YouTube site is talking about what to look out for after treatment, signs and symptoms. And because you're absolutely right, you've identified sort of really, really correctly that for most women, or all women, I would say, they have to get used to a new normal for them. And particularly for those women that go on and have radiotherapy, those changes can happen for quite a long time after their treatment ends as well. So it can be quite a confusing time. So it is just having that good practice of breast awareness or body awareness, so that if any changes are detected, you can get those checked out. As I said, we offer an open access service. So if there's sort of, you mentioned knobbly bobbly bits, and if they are there and you're at all concerned, then it's always good to give us a call so we can get those checked out. And if necessary, get them assessed in the breast clinic.
Thank you, Sharon. Harriet, somebody's asked, if I have side effects from hormone treatment, can I have a lower dose or a different hormone therapy?
Thank you. It's a good question, because while we try to reduce the risk from a cancer, we also want to maintain the best quality of life possible. So if there are side effects from the medication, dose reductions may not be possible for hormone preparations like they are for chemotherapy. And in these cases, we would encourage everyone to contact the breast care nurses, because there may be advice and they may offer guidance on how to manage some of the side effects, mainly if there are menopausal symptoms. However, if these adjustments are not enough to allow treatment to continue with a good quality of life, we can easily explore other options. So yes, please contact the breast care nursing team and we should be able to explore other ways to minimize the toxicity or change the preparation if we have to.
Thank you. So somebody's asked, what sort of recovery support is there out there for me and my family? We've had a tough year, especially my husband, who worries that I'll get cancer again. I guess I can answer that in that from a Macmillan Information and Support Centre. The service we offer is indefinite. We complement the key workers and the specialists in that we provide general advice and support. If your concerns were clinical or side effects or symptoms or anything, we would refer back to the nurse specialists and the medics. But for us, certainly what we find post-treatment is sometimes people do have concerns or struggle. They have time to reflect on what's just happened in terms of diagnosis and treatment and need some support just to go forward. So we do have a prospectus where we offer some health and well-being support. It can be like the Hope course, for example, that is a 6-week course aimed at getting people together so they can offer each other peer support, but also build up resilience on coping with any challenges going forward and building up resilience. We do mindfulness. We talk about the good pillars of good health, relaxation, communication skills, all sorts of things. We're always trying to get people together so that they can support one another, because that works really well. So we try and do all sorts like coffee mornings. We've got our walking group and our yoga offer as well. So like I say, we will always signpost to anyone that might be able to help you as well, but it's just having that initial conversation, and that can be formally as a one-to-one in the centre, or you can just pop in and have a cup of tea. It's just starting that conversation, I think, and then for us to guide you who best can support you. I don't know if there's anything else anyone else wants to sort of add.
No, I would just say that I think breast cancer patients often really enjoy the contact with people they meet that are undergoing treatment, and there is a support group for primary and secondary breast cancer. So I think the resource is out there, and I know from feedback from our patients, and I'm sure Sharon has the same, some people find that incredibly reassuring. It's not for everybody, but I think for a lot of people to have contact with people that understand the journey they've had is really important.
Yeah, absolutely. Thank you, Ruth. Yeah. This is for Ruth. Somebody's asked, I've been referred to the community palliative care team this week by my secondary breast care nurse. What's the difference between my nurse at the hospital and the community nurse?
Okay. We have a lot of contact with the palliative care team in the community. The nurses do an amazing job, particularly with things like symptom control. And because they're in the community, of course, they can come out and see patients in their homes, or invite them to their own clinics, whereas we are sort of very much hospital bound, the CNS team. So I think that communication between primary and secondary care is incredibly important, and we do often speak to our colleagues that we have the patients in common with, so they'll go out and sort things out and feedback to us. So yes, anybody that has symptoms that can't sort of be controlled easily in a hospital review really benefit from having input from the community staff. I hope that answers that okay.
Thank you. So somebody said, I see Kay is a dietitian. How do we get to see her if needed?
I'm in a bit of a weird position in terms of the fact that I'm part of the prehab team at Northampton General. So I'm seeing sort of people currently, our service is sort of open to people pre-surgery for specific types of cancer. Next year it'll be rolling out to other sort of treatments, including sort of chemotherapy and hematological treatments. But at the moment, to actually see myself, it would be a referral via your CNS if you meet our criteria. More sort of generally, if you're not sort of going for surgery at the moment, then there is the main sort of dietitians department, which is based in Highfield, just on the edge of the hospital grounds. And depending on sort of where you are in the treatment pathway, it may well be that you can get referred to dietitian called Keith, who's based at Highfield, who is a sort of specialist oncology dietitian, or depending on your needs as well, there's the community dietitians that you can be referred to. So if you're not currently sort of under a sort of clinical nurse specialist at the hospital, then it may be worth liaising with your GP surgery, and then they can refer you to the community dietitian. So there are a number of different avenues available, but it depends on why you're wanting a referral and what input you're needing, really, of which is the best route. So sorry, there's no sort of one straightforward answer to that question, but hopefully that's helped. But do pop in the chat if it hasn't.
Thank you, Kay. We've had a couple of queries at the centre about the COVID jabs that people are being offered, and is it safe whilst having treatment?
Thank you. So it is indeed that time of the year again when COVID jabs are being offered, and so we sometimes hear these questions in clinic. In terms of safety, there is no contraindication, and they are actually recommended for patients who undergo active anti-cancer therapy to minimize the risk of COVID complications. So there are no strict contraindications unless someone has had a previous reaction to the COVID jab. And sometimes there are queries regarding the best timing of the COVID jab or any vaccination. And we tend to recommend having it done towards the end of a treatment cycle, because the body's immune system might be at its lowest in the second week of a typical 3 week cycle. It may not be the case for all anti-cancer drugs, so it may also be worth checking with the specialist nursing team based on the exact treatment that is being received. So there is no contraindication. We tend to recommend having it done towards the end of the cycle, because that's when the immune system recovers, and in theory we expect the immune response to be slightly better. The only problem with the COVID jab is if the reaction the body has to the vaccine is mimicking an infection, but knowing that the jab was given recently may sometimes help differentiate between the two. And yes, it is something that is recommended unless there is a strict contraindication.
Thank you for that. Thank you. There's a question: is our immune system still affected after cancer treatment, or will our immune system recover back to normal? Hence, do I still need COVID jabs?
Indeed, that's this question highlights what we know about COVID and what we don't know about COVID and how the immune system works. Because in our daily practice, when we assess patients and we assess the immune system and how safe it is to have another dose of chemotherapy, we look at the number of white blood cells. And sometimes I use the comparison with looking at an army that's meant to protect us from infections. So we get to know the white blood cell counts, so we get to know the size of that army. But what we don't always know is how well prepared or how well trained that army is. So we don't know how effective the immune response is, because that involves a lot of substances being produced and cells communicating with each other. So we tend to assume that the immune system recovers after chemotherapy after 3-4 weeks based on the recovery that we see with the blood cell count. It may not be the case in how the immune system functions. And I'm not sure if there is a definition at this point on how long patients are maybe slightly more vulnerable for after receiving anti-cancer drugs, and how soon after treatment the recovery is complete. So we tend to be really guided by how patients feel. We recommend the COVID jabs if they are being offered in the first 3 weeks after chemotherapy. But once treatment is completed, if there was a previous exposure, previous vaccination, there is also the possibility for that to offer enough protection from severe complications from COVID. So then the jab may be an option, not necessarily something that's a strong recommendation. So it's difficult to answer that question, unfortunately, because the data is not quite there yet. But from what we've observed with patients, even during chemotherapy, the severe cases of COVID are no longer as frequent as they were back in the days before the vaccines were offered, and any previous exposure reduces the risk of the severe form of COVID.
Thank you, Henrietta.
It says, if you already have lymphedema, can reconstruction make it worse?
Shall I take that? So lymphedema, once somebody has that, it is something about that we have to manage rather than completely get rid of. So if it was reconstruction as a delayed procedure, which is what I'm kind of thinking that question means, then yes, certainly you could see an exacerbation of that initially post-operatively, even if we weren't going up into the armpit again. As I say, if it was a delayed procedure, we wouldn't necessarily be taking any more lymph nodes and things out. But if somebody was already affected, then it could exacerbate that just from the fact that we're performing surgery. Build-up of fluid is very common after breast surgery. We use drains and things like that to try and minimise the chance of that. But obviously, with a previously compromised lymphatic system, yes, it could be exacerbated. And it would just be a matter of continuing with the management plan from that, really. Yeah, it would be difficult to predict everybody as to how they would go, but there could be a risk of not necessarily a permanent increase in it, but certainly there could be initially post-operatively a worsening of symptoms at that time that would need managed.
Thank you, Sharon. So we've got, can I add to that answer? I was told the back flap would not be an option for reconstructive surgery. Are you able to build on that, Sharon?
Sorry, what was that second question? Sorry.
Can I add to that? I was told that the back flap with lymphedema would not be an option for reconstructive surgery.
Yeah, so with if from the back flap, I'm thinking that might be the latissimus dorsi or the LD flap reconstruction, which is where we move the latissimus dorsi vessel round to the front to rebuild the breast. There's quite a significant risk of fluid buildup, as I mentioned in my previous answer, where we do use drains and things, but it can be quite a significant problem for patients. And if they've all, as I said, particularly if it's a delayed procedure, if they've already got lymphedema, yes, that could be a problem. That could be a problem. I'm hoping I'm answering that right. Sorry, it's hard with sort of limited information. Is that okay?
Is that okay? Yeah, do put anything else in the chat box if you want anything sort of clarifying or any more info.
Equally, for whoever's asking those questions, if it's easier for you to give us a call and we can talk in more detail with your specific clinical information, that can also sometimes be easier for us to be a bit clearer in our answers. So if you don't feel that I've answered that question properly tonight, I do apologise. As I say, feel free to get a bit more clarity by contacting us and we can talk in a bit more detail.
Thank you. And Laura's popped some details up on the screen. Oh, thank you. So a lady has said, I would like to say thank you for this session. Very helpful. Oh, that's really good feedback. Thank you. We haven't run one of these for a while. We were trying to work it out, and it was probably towards the end of 2021. And it's something we've wanted to do because it's been helpful before in the past, hasn't it? So hopefully it'll be something that we can do again, because it just gives you a chance to be able to ask a number of healthcare professionals here any questions that you might have, queries. So thank you for that. So we will end the session. So thank you for logging on and joining us today and being part of the live Q&A. Look on our website and Facebook and Instagram pages. We've got some details just for anything else that's up and coming. We try and we try and sort of put as much info out there so that we reach people so they know what's happening and what's being offered. So we tend to put stuff on our Facebook page, our Instagram, Twitter, and then our website as well. Okay, so thank you everybody again for joining us, and you've got our details if you need to contact us in the meantime for any further advice and support. Thank you.
Thanks very much.
Thank you. Bye.
Bye.